Actually, what we're talking about here, salvage surgery after primary radical prostatectomy and then biochemical recurrence, is not a guideline approved approach of prostate cancer treatment. So normally patients who progress after radical prostatectomy and maybe then local radiotherapy, they then face systemic therapy. But with the advancements of imaging, and especially PSMA-PET, salvage treatments, local salvage treatments, metastasis-directed therapy, and also salvage surgery are more and more coming into focus. And and that was still at the time when I was in Munich, we also could utilize those PSMA traces for intraoperative tracking. So we labeled them with gamma emitting isotopes, and that made it a lot easier now to find those small lymph node metastases seen on PSMA-PET. And this triggered basically the interest of physicians, of patients to pursue those treatments. However, I would say the good point is not finding a lesion, of course, and confirming that you have found a PSMA-avid lesion, but the good result would be for the patient to have a significant drop of PSA and maybe be PSA-free for a certain time and therapy-free for a certain time. So it is crucial to identify suitable patients. And in the study that we also now could publish in European Urology and also discussed here at the EAU meeting, we looked at a cohort of over 360 patients after radical prostatectomy with biochemical recurrence, and they had all a PSMA-avid lesion and pursued then to salvage surgery. Of course, we talked about the individual treatment approach. And then we followed those patients. So it was a consecutive patient cohort, and we found that a significant proportion of patients had a significant drop in PSA, but also stayed PSA-free for a longer time. The median PSA-free survival was only seven months or so. But when you look now at the best cohort, and now with this cohort, we can analyze which are the best factors. And it turns out that patients, of course, with low PSA, with only a few lesions, 1-2 lesions on PSMA-PET, and with the lesion location in the pelvis and not the retroperitoneum, are the best candidates. And for those candidates, they remain therapy-free and PSA-free for quite some time. So for the whole cohort, the therapy-free survival was 3 years. So no hormones, no adjuvant radiation or so given. But when you look at the good cohort, we have not even reached the median therapy-free survival. And I believe the BCR-free survival was at least 1.5 years.